Imagine this scenario. It's a chaotic Friday night. You've got an 18-year-old university student. He's working a part-time hustle delivering pizzas.
Right.
He's on a motorcycle, the engine is revving, his boss is probably yelling into the earpiece for quicker deliveries, so he's, weaving in and out of this gridlock traffic.
I could picture it. It's a recipe for disaster.
Exactly. He sees a gap between a sedan and a truck, guns the engine, and misjudges it. A car bumper violently strikes the outer surface of his left knee.
Oh, a direct impact.
A direct, blunt force hit. Now, he doesn't crash the bike. He manages to keep it upright amazingly, but the impact is nasty. He limps into the ER an hour later because his leg just, quote, doesn't feel right.
And that is a classic trauma mechanism. It's high energy, it's a focused impact, and I'm assuming, given the pain and the limp, the first thing on everyone's mind in that ER is a fracture.
That's it. Everyone is thinking broken bone. But here's the twist, and this is where our story really starts. They rush him to radiology, they do the x-rays, and nothing.
Yep.
The knee looks fine. The tibia and femur are intact, no broken bones. But the clinical exam tells a completely different story. The kid can't lift his foot off the bed.
At all.
Can't dorsiflex. And he can't turn his foot outward. And on top of that, he's complaining about this weird patch of numbness on the front and side of his leg and the top of his foot.
So wait, structurally, the scaffolding appears totally intact on the x-ray, but the foot has essentially stopped receiving instructions from headquarters.
Precisely. The doctors diagnosed him with foot drop. But if the bone isn't broken, what is happening inside that leg? That, my friends, is the mystery we are going to solve today.
And it is a mystery that takes us right into the fascinating, complex architecture of human movement. It's a perfect entry point.
Welcome back to the deep dive. Today we are cracking open the lower limb chapter of Snell's clinical anatomy. Now, before we go any further, I have to say something important about how we're approaching this. We are relying on Snell's as our source of truth, but we are not just going to read the book to you.
Right. That's not the point. We want to interpret this chapter. We want to pull out the golden nuggets, the mechanical principles, the real aha moments. Think of this conversation as a companion piece.
A ready reckoner, if you will.
Exactly, a ready reckoner.
I feel like reading deep textbooks is becoming a lost art, isn't it? It's so easy to just Google a symptom or watch a quick video.
It is. The patience for deep reading is waning.
But we want this deep dive to be the spark. After you listen to this, we want you to actually go grab Snell's, open it up to the lower limb chapter. We won't give you the chapter number because editions change, but look for lower limb and look at the diagrams.
Please look at the diagrams.
Treat this as your guide, but the book is the territory.
That is so well said, because anatomy is a visual sport. We can describe the suspension bridge of the foot or the shelf bracket of the hip, and we will, but you really need to see it to own the knowledge.
So, here's our roadmap. We are going to travel down the limb geographically. We'll start at the foundation, the hip girdle. We'll move through the thigh to that incredibly dangerous knee joint, and finally down to the complex engineering of the foot.
And we'll keep coming back to our pizza delivery driver.
We will. To understand why knowing exactly where a nerve sits relative to a bone can save a patient's ability to walk.
So let's start at the top.
The hip.
The foundation. Now, Snell makes a really interesting comparison right off the bat between the upper limb, the shoulder and arm, and the lower limb.
It's a comparison of function versus form, really. If you look at your shoulder, the clavicle and scapula are designed for mobility. I mean, you can reach behind your back, over your head, scratch your ear. It's a massive range of motion.
Incredible range.
But the lower limb has a completely different job description. It is all about stability and locomotion. Weight bearing.
It's the difference between a crane and a pillar. Exactly. The pelvic girdle, formed by the two hip bones, or os coxae, and the sacrum, is built to bear weight. It's locked in tight. You have the sacroiliac joints at the back and the symphysis pubis at the front.
It's a solid ring of bone.
It has to be. It has to support the entire weight of the upper body, your head, your torso, your arms, and transfer all that force down into the legs. It can't be wobbling around like a shoulder.
And the main connector there is the femur, the thigh bone. Now, I want to unpack something that I found fascinating in the text, and I think it's something people glaze over. The neck of the femur. Snell talks about the angle of inclination. This feels like high school geometry, but it seems critical for how we stand and walk.
It is absolutely critical. And to understand it, we need to visualize the bone. Imagine the femur. You have the long shaft that goes down your thigh.
Sure.
If this were a simple table leg, it would just go straight up into the hip socket. But it doesn't.
Right, it takes turn.
It takes a hard turn. At the top of the shaft, The bone turns inward to form the neck, and then ends in the head, which fits into the socket. That turn creates an angle between the shaft and the neck. That is the angle of inclination.
Okay, hold on. I want to visualize this. Because when I think of a pillar supporting a building, I think of a straight column, straight up and down. But you're saying the femur comes up the thigh and then acts like a street lamp that hangs out over the road.
That's a great analogy. It's an offset. It really is.
But isn't that structurally weaker? I mean, if I stand on a bent stick, it snaps. Why wouldn't evolution just give us straight legs that go right into the socket?
That is the million-dollar question. And the answer is about movement. If the femur went straight up, we would be incredibly stable standing still, like a statue. But we wouldn't be able to walk efficiently.
Why not?
Because that angle, that offset, creates a lever arm.
A lever arm for what?
For the gluteal muscles, specifically the gluteus medius and minimus. These muscles attach to the top of that street lamp, the greater trochanter. Because the bone sticks out to the side before turning in, those muscles have better leverage to pull the leg out. Or, more importantly, to keep your pelvis level when you stand on one leg.
Ah, so the bend gives the muscles a mechanical advantage.
Precisely. It's pure physics. In a healthy adult, that angle is about 125 degrees.
That's specific, 125.
It's the sweet spot. In children, it starts wider, about 160 degrees, but as we walk and bear weight, it settles to that magic number of 125.
But like anything in the body, angles can go wrong. The text mentions coxavalga and coxavara. These sound like Harry Potter spells, but I know they're medical conditions. Break them down for us. Why do we care if the angle changes?
Think of that street lamp again. Or maybe a shelf bracket holding up a heavy bookshelf. A normal bracket is at a specific angle to hold the weight and allow room underneath. Coxavalga is when that angle increases, it gets straighter.
So instead of 125 degrees, it's wider, more like 140, 150, more vertical.
Yes. The bend is less pronounced. You see this in things like congenital dislocations of the hip. The problem is, if that angle is too straight, you lose that lever arm we just talked about.
The mechanical advantage is gone.
It's reduced. And it limits adduction. That's bringing the leg toward the midline. The whole mechanics of the hip are thrown off.
And coxavara is the opposite.
Correct. The angle decreases. It bends more. So less than 125 degrees. This is really dangerous because it increases the shearing force on the neck. It's like bending that shelf bracket down. Eventually, the metal fatigues and snaps.
Right.
You see coxavara in fractures or conditions where the femoral epiphysis slips in adolescence. And it limits abduction. That's moving the leg away from the body.
So that angle, 125 degrees, is this Goldilocks zone. Too straight, you lose leverage. Too bent, you risk snapping the bone.
And that leads us directly to one of the biggest clinical red flags in the hip section. Fractures of the femoral neck.
This is the classic grandma fell and broke her hip scenario, right?
It is, absolutely. Yeah. But Snell points out something that makes this injury particularly devastating. It's not just about the bone breaking. It's about the blood.
The vascular danger zone.
Yes. This is a concept every medical student needs to anchor in their mind. The head of the femur, the ball that sits in the socket, gets its blood supply from very specific, very delicate arteries.
They're fragile.
They are. Specifically, the retinacular branches of the medial circumflex femoral artery.
Medial circumflex femoral artery. That's a mouthful.
Circumflex just means bending around. It wraps around the bone. These little arteries run right along the neck of the femur, almost like vines growing up a wall.
I see where this is going. If you fracture the neck...
You tear the vines, you tear the fuel lines, and when the blood supply is cut off, the bone tissue in the head of the femur dies. That's called a vascular necrosis.
Necrosis is never a word you want to hear.
No. It means cell death. And that's why a femoral neck fracture in an elderly patient is an emergency. It's not just, let's put a cast on it. The bone itself is dying because the supply line is cut. Often, the only solution is to replace the head of the femur entirely. A hip replacement.
That is a crucial insight. It's not the crack in the bone that's the long-term killer. It's the starvation of the tissue. Okay, let's move down. We've got our stable hip, our angled femur. Now we arrive at the knee.
The largest and most complicated joint in the body.
And also, seemingly, the one most prone to blowing out when you're skiing or playing soccer.
Well, it's because of the mechanics. The knee is essentially two main joints wrapped in one capsule. You have the condylar joints, where the rounded ends of the femur sit on top of the flat top of the tibia.
Like two bowling balls sitting on a platter.
Kind of, yeah. And then you have the gliding joint, where the patella, or kneecap, slides against the femur.
Now, before we get into the mechanics of the knee, I want everyone listening to do something for me. If you're sitting down, or even standing, Reach down and grab your knee. Feel the big bony hinge there.
You're feeling the femur meeting the tibia, the main load bearers.
Now slide your hand down the outside of your leg, just below the knee joint. You'll feel a smaller, knobby bone sticking out on the side.
That's the head of the fibula.
Here is the mind-blowing part for me, and Snell puts this in bold letters. That bone you are touching, it has absolutely nothing to do with the knee joint.
It's deceptive, isn't it?
Yeah.
It's sitting right there at the party, but it wasn't invited to dance.
So if I jump off a wall and land on my feet, the impact goes femur into tibia. The fibula takes, 0% of the weight?
Almost zero. It's not a weight-bearing pillar. It's actually more like an anchor point. It's there because your biceps femoris muscle needs a place to grab onto, and ligaments of the knee need a stabilizing post on the side.
It's the sidecar on the motorcycle.
That is a perfect analogy. The tibia is the motorcycle carrying the passenger. The fibula is the sidecar. It adds stability, it widens the base, but the engine and the wheels are all in the main frame.
But, and this is a huge but, just because it doesn't bear weight doesn't mean it's safe. In fact, its location makes it a target. And this connects directly back to our pizza delivery driver, which we will get to in a moment.
We will.
But first, let's talk about the patella, the kneecap. It's a sesamoid bone, which means it sits inside a tendon, right?
Correct. It sits inside the massive quadriceps tendon. It acts like a fulcrum to increase the leverage of the quad muscles. But think about the forces here. Your quad muscles run down the front of your thigh, but they pull slightly upward and outward. Why doesn't the patella just pop off the side of your knee every time you squat?
That's the dislocation dynamics part of the text. It seems like it should dislocate laterally.
It wants to. The physics of the Q angle, the angle of the quads pulling, naturally drags it outward. But anatomy provides a shield. There are two main guardrails preventing lateral dislocation. First, the shape of the femur itself. The lateral condyle, the bump on the outside of the femur, is larger and sits more forward than the medial one. It acts like a physical wall or stopper.
Like a guardrail on a sharp curve.
Exactly. And the second guardrail is muscular. The vastus medialis muscle, that teardrop muscle on the inside of your thigh, has lower horizontal fibers that pull the patella inward, countering the pull that wants to drag it outward.
So you have a bone barrier and a muscle tether keeping it on track. It's a double lock system.
Which explains why dislocation happens when it does. Snell notes that traumatic dislocation usually happens with direct trauma to the quadriceps attachments, or if that lateral condyle is underdeveloped congenitally. If the guardrail is too small, the car goes off the cliff.
Before we leave the knee, we have to mention the locking mechanism. Snell calls it the screw-home mechanism. This explains how we can stand in line at the grocery store for 20 minutes without our legs turning to jelly.
It's brilliant engineering. When you fully extend your knee, like when you're standing straight, the femur rotates slightly medially on the tibia.
It turns inward.
Just a little bit. It essentially screws the joint tight. The ligaments become taut, and the bones lock into place.
So you're hanging on your ligaments, not your muscles.
Right. You can relax your quad muscles and still remain upright. To sit down, a small muscle behind the knee called the popliteus has to unscrew or unlock the joint to let it bend again.
It's basically a parking brake for your legs.
A very, very efficient parking brake.
Okay, let's travel down below the knee. This is where we get back to our pizza delivery driver. This is the section Snell really dives into. The leg. And specifically the concept of fascial compartments.
This is fundamental to understanding the lower limb.
Yeah.
The leg, and when we say leg in anatomy, we mean strictly the part between the knee and ankle, is wrapped in a tough, non-stretchy layer called deep fascia.
Like a sausage casing.
A very tough sausage casing. And inside that wrapper, there are wall septa that divide the leg into three distinct rooms or compartments.
The anterior, the lateral, and the posterior. Like a bento box.
A bento box, where the walls are made of gristle. And here's the rule. Each compartment has its own team of muscles, its own blood supply, and its own nerve. They are self-contained units.
Okay, so let's visualize this. The anterior compartment is the front. What does it do?
Its main job is dorsiflexion, pulling the foot upward, toward the shin. Think of lifting your foot off the gas pedal.
Got it. And the lateral compartment, the outside.
Aversion, turning the sole of the foot outward, away from the midline.
And the posterior, the calf.
That's the big one. Plantar flexion, pointing the toes down like standing on tiptoes or pushing the gas pedal.
Okay, listeners, I want you to picture the pizza driver again. He's weaving through traffic. A car bumper hits him. Where did it hit? Snell says. violently struck the outer surface of his left knee.
The lateral side?
The lateral side. So if you get hit hard on the lateral side of the knee, just below the joint, what is sitting right there?
This is the solution to the mystery. The common fibular nerve.
The common fibular nerve, also called the common peroneal nerve in older texts.
Right. And to understand why this nerve is so vulnerable, you have to think about protection. Most major nerves in your body are buried deep. They travel through the middle of the meat, protected by inches of muscle. The sciatic nerve, for example, is buried under your glutes.
It's high-value infrastructure. You bury the power lines underground.
Exactly. But the common fibular nerve, it makes a very, very risky navigational choice. To get from the back of the knee to the front of the leg, it has to cross over the bone. Specifically, it winds around the neck of the fibula like a snake.
That bone we were just touching, the sidecar.
The very one. And at that specific crossing point, what's covering it?
Not much, I'm guessing.
Skin.
Mm-hmm.
And maybe a millimeter of fat. That's it. It's entirely subcutaneous. It's right there under your fingers.
So when our pizza driver is on his bike, his leg is exposed. The car bumper hits the side of the knee. It doesn't have to break the bone, does it?
No, absolutely not. Think of the nerve like a garden hose. If you lay a garden hose on a concrete driveway, that's the bone, and drive a car over it, you crush the hose. You don't need to crack the concrete to stop the water flow.
That is a terrifying image. And the water, in this case, is the electrical signal telling his foot what to do.
Correct. And this nerve, the common fibular nerve, is the boss of two compartments. It's the main trunk line that then branches.
Okay.
It splits into the deep fibular nerve, which supplies the anterior compartment, and the superficial fibular nerve, which supplies the lateral compartment.
So if you crush the main trunk, the common fibular nerve at the neck of the fibula, you knock out both teams.
Exactly. You knock out the anterior team, so you lose dorsiflexion. You can't lift your foot. That results in foot drop. Gravity just pulls the foot down into a plantar flexed position.
And you knock out the lateral team.
So you lose aversion. You can't turn the foot out. The foot then tends to turn inward or invert because the muscles on the inside are still working and pulling unopposed.
This explains the symptoms perfectly. The ER doc saw a foot drop, saw the inability to avert, and because the nerve also carries sensory information.
That explains the numbness on the front and side of the leg and the top of the foot. It fits perfectly. It is the most common nerve injury in the lower limb simply because of where it sits. It's a design flaw, if you want to call it that.
Let's talk about those consequences. Foot drop sounds inconvenient, but it changes how you walk completely. Snell describes the high steppage gait.
Try to walk without lifting your toes. Seriously, you can try it right now. If you just swing your leg forward normally, your toes will drag on the ground and you'll trip.
You'd catch your foot on everything.
So the patient has to compensate. They lift their thigh up high, like a marching soldier or a horse, to clear the toes off the ground before slapping the foot down. It's very distinctive.
That is a vivid image, the body trying to hack its own failure.
It is. And for a physician, observing that gait is the first clue. As soon as you see that high step and the foot slap, your brain should scream, common fibular nerve.
I want to do a quick check-in here for our listeners. This is a nuance that Snell highlights, and it's a great way to test if you're really getting it.
Go for it. This is a good one.
Okay, listener. We just said the common fibular nerve controls both the anterior compartment for lifting the foot and the lateral compartment for turning it out. Now imagine a patient comes in, they have foot drop, they can't lift their foot. But T, when you ask them to turn their foot outward avert, they can do it. Where is the injury?
Excellent question. Think about the branching, the family tree of the nerve.
If the main trunk, the common fibular at the knee, was hit, both functions would be gone. But here, aversion is safe.
Which means the lateral compartment is still getting a signal. The superficial fibular nerve is working.
So the injury must be?
Has to be downstream. It's isolated to the deep fibular nerve, or maybe the anterior compartment itself. Maybe there's a localized swelling compartment syndrome or a deep cut specifically on the front of the ankle. It tells you the injury is not at the neck of the fibula.
See. Anatomy is detective work. It's about localization. If you're fuzzy on that, rewind and listen to the compartment breakdown again. It's crucial to distinguish between the trunk and the branches.
And this detective work continues as we move down to the foot.
The foot. Leonardo da Vinci called it a masterpiece of engineering and a work of art. Snell calls it a functional unit.
It has to be. It does two opposing things. It's a rigid lever for pushing off when you walk, but it's also a flexible shock absorber when you land. And it does this through arches.
A suspension system.
We have three main arches. The medial longitudinal arch, that's the high arch on the inside of your foot. The lateral longitudinal arch, the lower one on the outside, and the transverse arch, which goes across the ball of the foot.
And Snell uses a great metaphor here. He compares the foot to a segmented lever or a stone bridge.
Think of a Roman stone arch bridge. What holds it up? First, the shape of the stones. The bones of the foot act like keystones. They are wedged together.
They lock into place.
Second, the mortar or the ties. These are the strong ligaments binding the bones together. And third, and this is the dynamic part, the muscle tone. The tendons that cross the sole of the foot act like bowstrings.
So it's a dynamic bridge. It's not just concrete.
Exactly. The ligaments are like the cables on a suspension bridge. If they stretch or snap, or if the muscles get tired and can't maintain the tension, the bridge sags. This is what happens in pes planos or flat foot.
The medial arch collapses.
Right. Usually it's because the muscle tone fails or the ligaments stretch out. The head of the talus bone, one of the ankle bones, drops down, and the foot flattens. It's like the keystone of the bridge slipping out of place.
The text also mentions some specific congenital conditions, things babies are born with. I think it's important to touch on these because they illustrate how muscle balance shapes the bones. Clubfoot is the big one. Talipes equinovarus.
This is a significant deformity. And let's break down the Latin because it tells you exactly what it is. Talipes means ankle and foot. Equinovi means like a horse.
Like a horse.
Yes, think of a horse's hoof. It points down. So the heel is up and the toes are down. That's plantar flexion. And varus means turned inward. So the foot is pointed down and twisted in.
And Snell says this is caused by muscle spasms or contractures. The muscles are just too tight.
It's often a tightness in the muscles on the posterior and medial side. They pull the foot into that position and hold it there while the bones are developing. You have to correct it early, often with serial casting or surgery, to reshape the stones of the bridge before they harden in the wrong position.
There's also metatarsus foris and curly toes.
Curly toes is surprisingly common. The flexor tendons are too tight, pulling the toes, usually the fourth or fifth, underneath the others. Again, it's a tension problem. The string is too short for the bow.
Let's get tactile for a second. Surface anatomy again. I want everyone listening to reach down and touch their ankle. You feel those two big bumps on either side.
The malleoli. Medial malleolus is the bottom of the tibia on the inside. The lateral malleolus is the bottom of the fibula on the outside.
Now, notice something. They act like a pulley system for the tendons.
They do, but more importantly, they form the roof of a tunnel. Snell emphasizes this. All the major structures, nerves, blood vessels, tendons that go from the leg into the sole of the foot have to pass behind or around these malleoli.
They don't just go straight down the front.
Some do, like the extensors to the top of the foot, but the vital supply line to the sole of the foot, the posterior tibial artery and the tibial nerve, runs in a protected groove behind the medial malleolus. It's called the tarsal tunnel.
So just like the fibular nerve at the knee, we have another choke point at the ankle.
Exactly. If you have swelling there from an ankle sprain or a ganglion cyst, you compress the nerve and you get numbness or pain in the sole of the foot. It's the same tunnel concept as carpal tunnel in the wrist, just in the ankle.
It's amazing how these patterns repeat. Narrow passages, vulnerable nerves. It's a recurring theme.
That's the theme of the lower limb. Big, strong levers powered by muscles inside tight compartments with nerves and arteries threading the needle between them.
Let's bring this all home with some clinical reality checks. We've talked about the pizza driver. We've talked about grandma's hip. Let's construct a scenario to test our listeners' clinical instinct.
I like it. Let's do it.
You're in the ER. A patient comes in with a fracture of the neck of the fibula. Maybe a soccer player got kicked hard on the side of the leg. You see the break on the x-ray. You're about to put a cast on it. What must you do first?
Based on the pizza driver case, you absolutely must test the common fibular nerve. You cannot just treat the bone and ignore the wire running next to it.
How do you test it? What are the exact steps?
It takes 2 seconds. First, sensation. You lightly touch the skin on the top of their foot, the dorsum. You ask, can you feel this? Then motor. You say, pull your big toe up towards your nose. That tests the deep fibular nerve. Then turn your foot out like you're looking at the sole. That tests the superficial fibular nerve.
If they can't feel it or they can't pull up,
then the nerve is damaged. And you have to document that before the cast goes on. If you put a cast on without documenting that, and the cast comes off 6 weeks later and they have a permanent foot drop, they might think the cast caused it. You missed the primary diagnosis.
That is a career-saving and patient-saving tip. Always check the nerve downstream from the fracture.
Always. every single time.
Okay, second scenario. We touched on this, but let's hammer it home. An elderly patient complains of hip pain after a minor stumble. They can still walk, but it hurts. Why is this a drop everything moment? Why not just say, take some ibuprofen and rest?
Because of those retinacular arteries we talked about, the blood supply. If there is a hairline fracture in the femoral neck that you ignore, an undisplaced fracture, and the patient keeps walking on it, they could displace that fracture. The bone ends could shift.
And if they displace it?
They tear the arteries. They go from a simple fracture that might heal with a screw to a vascular necrosis where the femoral head dies and needs a full complicated hip replacement. The difference is the blood supply. Time is tissue.
It connects back to the very beginning. The hip is the foundation. If the blood supply to the foundation is cut, the house falls down.
Precisely. It crumbles from within.
We've covered a lot of ground today. We started at the hip, visualizing that femoral neck angle, the shelf bracket, and why 125 degrees is the magic number for leverage and stability.
We did.
We moved to the knee, realizing the fibula is just a spectator to the joint, but a VIP for the nerve that wraps around it.
The very vulnerable VIP.
Then we spent time in the compartments of the leg, understanding how the common fibular nerve is the Achilles heel, pun absolutely intended of, the leg's motor supply. Remember the pizza driver. Lateral knee hit, foot drop.
It's a classic cause and effect.
And we finished at the foot, viewing it not as a block of bone, but as a dynamic suspension bridge held up by ligament tension and muscle tone.
And that leads me to my final thought for you, for the listeners.
Let's hear it.
This brings us to a sort of philosophical shift in how we view the body. We grow up looking at skeletons in science class. They are dry, white, brittle things. We think of anatomy as scaffolding.
Like the steel beams in a skyscraper. Once they are up,
Yeah.
Stable, permanent.
Right. But what Snell is teaching us here, what clinical anatomy teaches us, is that the lower limb is not a skyscraper. It's a dynamic, pressurized hydraulic system. The arch of the foot isn't an arch just because the bones are curved. It's an arch because the muscles are pulling tight like bowstrings.
If you cut the string, the bow straightens out.
Exactly. And the head of the femur isn't just a ball bearing. It's living tissue that will rot and die within hours if those tiny retinacular arteries are torn.
So it changes the way you look at a patient. You aren't just checking if the parts are broken. You're checking if the system is flowing.
That's the takeaway. The pizza driver had unbroken bones. His scaffolding was perfect on the x-ray. But his hydraulics, the nerve flow, was crushed. And that rendered the scaffolding useless.
So the provocative thought for the listener today is this. Where else in your life or your work are you focused on the hard structure while ignoring the flow that actually keeps it upright? Because, as we learned today, the strongest bone in the body is useless without the most fragile nerve.
And please open the book. Look at the diagrams for the femoral triangle. Look at the cross-section of the leg compartments. See the path of that fibular nerve. It will make this audio stick in your brain in a way that just listening can't.
Snell's Clinical Anatomy, chapter, Lower Limb. Go find it, read it. Use this deep dive as your cheat sheet. Thanks for listening, everyone. Stay curious and watch out for car bumpers.
To stay safe.